This is the case of total anomalous pulmonary venous connection. This is by cable view. You can see this subcostal window is utilized to make this image, this view. Structure wise, this is IVC, this is SVC. So this portion is inferior portion, this portion is superior portion. This one is anterior one, this one is posterior one. So this one is the most prominent chamber is right atrium. This upper part is right ventricle. So you see the right ventricle is most anterior one and this SVC is most superior one. Here this portion is left atrium. The very small left atrium. Just I want to, this is left atrium. A for left atrium, RA for right atrium. This is tricuspid valve. This is IVC. This is bicable view, and this is SVC. SVC. To see the image, you can easily appreciate the IVC is very small in comparison to SVC. So SVC is getting more amount of blood. So why it is getting more amount of blood? Normally IVC is getting more compared to SVC, but in this scenario SVC is much more compared to IVC. Why? Because SVC has got some abnormal connection. So what kind of abnormal connection? You see the whole amount of SVC. Sometimes you get sinus venosus ASD, but so this portion will not be direct in that scenario. So ultimately this case has got total anomalous pulmonary venous connection and through left innominate vein, and that is draining into left innominate vein. Ultimately left innominate, right innominate joined together form superior vena cava. So ultimately superior vena cava is dilated because superior vena cava is getting lots of blood, amount of blood. So this is the case of total anomalous pulmonary venous connection of supracardiac variety. Again see the same thing. This is SVC flow. This is IVC. This is SVC. This is fourth chamber. We see this is right atrium. This is right ventricle severely dilated. This is the very small size of left atrium. This is descending thoracic aorta. This is aorta. This is left ventricle. So left atrium, left ventricle, very small in size. This is mitral regurgitation. This is tricuspid valve regurgitation. You can see. You can see this is short axis view, parasternal short axis view. This is left ventricle. This is right ventricle. Left ventricle is D-sept. You can see the D-sept. See the D-sept, indicating D-sept means this is D. You see the D-sept. This D-sept indicating severely raised right ventricular systolic pressure. That is D-sept. That is the point to know from this image. Again you see this is right atrium, this is right ventricle, this is left atrium, this is left atrial appendage, this is left ventricle, this is descending aorta, and this portion is pulmonary venous confluence. This is ASD. So from flow always has flow from right atrium to left atrium, because there is no communication, then child will not survive. So there must be some sort of communication, either ASD, VSD or PDA. So in this scenario, normally what I have seen, only ASD, not even VSD, because left atrium has to get blood, then it will get bloods from right atrium through ASD, then right atrium to left ventricle, then to pulmonary aorta, then aorta to whole circulation, then IVC and SVC to right atrium to right ventricle to pulmonary artery to pulmonary circulation, then pulmonary vein again that comes through left innominate vein to right atrium. So ultimately right atrium is getting almost all the blood. Left atrium getting mixed blood from right atrium, very small amount of blood, and that is why child is surviving, because it's getting little bit of blood. You can see very small ASD. This is a small ASD here. You can see this right atrium. This is SVC. This is very small left atrium. You can see this STR vein is joining the left innominate, but this is left innominate vein. This is aortic arch. This is aortic arch. This is left innominate. Always you see the flow in aortic arch and this straight vein will have opposite in color. So this is blue in color, aortic arch, and red in color is following straight vein. Straight vein means the vein that is coming from pulmonary venous confluence. All four pulmonary joints together make one chamber. From there one tube is coming, that is joining left innominate vein. That tube is called a straight vein, and this flow represents this straight vein. There is no flow obstruction in this scenario. Again you see this one. This follow through a straight vein. You can see two arches. This is aortic arch, this is follow through a straight vein into left innominate vein. This is aortic arch, this is aortic arch. This is flow through a straight vein into left innominate vein. You can see. This is aortic arch. You can see the aortic branches also, and this is left innominate vein. Here the straight vein joins to left innominate vein. You can see this straight vein is joining left innominate vein. So this is case of total anomalous pulmonary venous connection through left innominate vein, and that is called supracardiac variety. This is apical four-chamber view. So whenever you see apical four-chamber view, you have to suspect total anomalous pulmonary venous connection by seeing the large, huge dilatation of right sided structure. Same time ASD will reverse flow, very small left atrium, and then you have to find out common pulmonary venous confluence, and then the straight vein, then where it is draining. That is the point. Thank you.